Okay, so welcome back. We are into part 2 now. We were just finishing up our page 2, chief complaint and HPI. Don't forget to hit this down here if none of these factors affected the care of your patient, whether it be dispatch, response, scene, transport, or turnaround factors. Turnaround factors would be you end up spending a prolonged time at the hospital because of overcrowding or a natural disaster or whatever it may be. Generally, for most of the transports that we are involved in, we're going to set all the factors to none. Okay, so we have completed everything that we need to here on page 2. And because we put in a pretty moderate amount of data into here, we're going to hit next page. Remember to always change your page, whether it be going forward or backwards. Either way, it doesn't matter. But by advancing the page, it is going to ensure that all of your data is saved. So here, pages 3, 4, and 5, it breaks down your evaluation of the patient. So this is your initial encounter. This isn't what happens during transport. This is what you see as soon as you get to the scene. This is what you see on your first encounter with the patient. Everything that happens thereafter, whether it happened while you're carrying them from the home or whether it happened while you are en route to the hospital, that will all get logged under the activity log. Now, you'll also notice on this screen here that there's a new option down here for narrative. We have, by popular request, unlocked the option for people to write narratives again. If you would like to write a narrative, that is perfectly fine. You can do that, but you still, just remember, you still need to do all of these through here, and we'll get through exactly what you have to fill in. It's actually not that difficult. So level of consciousness, we know that Mr. John Doe is having a stroke and he's alert because he was able to answer most of our questions. Mental present, he is oriented to person, place, time. The easier thing to do here, instead of putting person, place, and time, we can say he's normal. That's just his mental status. Neurological present, this is where we get more into the stroke-like symptoms. So we're going to say that he's got leftward arm drift, he's got left hemiplegia, he's got left-sided weakness, he's got left-sided facial droop, he's got thick speech, so we'll say he's slurring his speech, and we should be good with that. Remember, anything that says not is a pertinent negative. Those do not need to be added in. We had talked about in the previous screen of chief complaint, putting in the duration of the complaint. Right here for registry candidates for strokes specifically, this is important right here. We want to know when they were last known well. It's something that we always standard get. Hey, tell me the last time you saw them normal, whether it be last night or whether it be 30 minutes ago. So we know that it was 30 minutes ago prior to us getting there on scene. So if I can't remember what time I got on scene, I can go back to my dispatch page here. And I know that we were dispatched at 22:30, so it began at about 10 p.m. So we're going to come back here, and we're going to say 2200 hours on the 27th, 2024, done. So over here, these are baseline set to normal. We had these as almost, if you will, think of them as like factory defaults. For the majority of the patients that we encounter, this is pretty standard. Most of them have normal pupil sizes. Most of them are reactive. Most of them have normal motor and sensory function. But because this is a stroke, we're going to want to make sure that we change these. So we're going to say his left arm is weak. We're going to say his left leg is weak. We're going to say his right arm and his right leg are fine. And we're going to say that his sensory on both of these sides are diminished. His pupils are still the same. They're still reactive, so we can leave those. If there were alterations in them, you can change them literally to anything you need to over here. But for now, for this demonstration, we'll leave them as normal. Our stroke scale is going to be a fast ED score. So we're going to say just on presentation, we know his fast ED is going to be positive because we know he's got changes and alterations to his speech. He's got unilateral weakness and he's got a forced right gaze. So we're going to say positive. This is going to unlock the stroke score. We're going to hit this. This can be helpful if you do not know the fast ED score right off the top of your head. Lowell General prefers that when we call in a stroke alert, that we provide them with the fast ED score. The fast ED score is important for the receiving physician to know, early ahead of time. If the fast ED score is greater than 4, then they are have a high likelihood of having a large vessel occlusion. So we're going to say, yep, we know he's got arm weakness. So he's got some weakness on one side, denial or neglect. We'll say that he's got some sensory deficit. His eyes are deviated. We said earlier that they were force deviated to the right. He's also got some facial weakness, and he's got speech changes. Now, because he's not aphasic, and is still able to communicate, but has thick speech, like I do right now, we're going to say it's mild or moderate. So it gives us a fast ED score of 6. So we know right now when we call Will General for the stroke alert, his fast ED score is 6. So that's done. Stroke symptoms resolved. If it's a TIA, sure, it could resolve while we're en route to the hospital, but we're going to say this guy's got a real stroke. So no, it has not resolved. These baseline default to 0. We're going to say that because he's awake, alert, and answering us normally, that his GCS is 15. So 4, 5, and 6. You can either do drop downs or you can hit the keys on the keyboard that correspond with them with the tab key, and it will get you right across that. So this is technically kind of covers your neuro exam right here, and this will print out on the report as a neuro exam. If there are things that aren't in here that you'd like to cover, like his force gaze to the right, you can add all that in here. I will generally add in quick little comments in here because I no longer write a long narrative in EMS charts. I don't use the narrative page at all. So in here, I'll write GCS 15, alert and oriented, times 3. He's dysarthric, so he's got thick speech, forced, right gaze, obvious, left weakness, fast, ED score 6. Now that is technically double documenting because I have covered all that in here. But in my brain, the way I see this, I like the way that looks a little better. And at the end of this patient care record, we'll go to the print preview so you can kind of see how that all lines up. So that's super easy. His airway status right here is patent, so we're just going to leave that. We don't need to add any comments. If you want to add comments, clear, patent, self-maintained. Done. Easy. But you don't have to because we've already talked about it right here. This is already selected as patent. If it was anything other than patent, if it was compromised, or if the patient was already intubated, say you went to assist Littleton with a cardiac arrest and they had already intubated the patient and you're documenting everything, you could say that the patient's airway was secured here, or we can say that it was compromised. But for this, we're going to say it's patent. And so that's all for this page. We'll move on to respiratory and cardiac. Respiratory status, it defaults his effort to normal because he's not having any respiratory distress. We're going to leave this as normal. We'll say we listened to breath sounds and they were clear. So we'll select clear and clear. The other alternative to this is you can highlight it and just hit the C button and enter, tab, C button, enter, and it covers all that. Done. If you want to talk about their respiratory status, so everything that comes down here, none of this is required. This is only required if you put the patient at this time on oxygen. If you have the ability to add humidification, if you have the ability to warm it. So this is more for high flow. This is more the critical care teams that use this. Down here in comments for respiratory, I'm going to put 14 a minute, non-labored, room air, sat 99%. Okay, done and easy. Cardiovascular now. This section right here, it defaults to radial pulses as strong. Remember, if this is a cardiac arrest, you absolutely want to get rid of this. You can bring it up so that it's clear, or you can make it say absent. This is also pertinent in somebody that is hypotensive. You can say they have no radial pulses and they have very weak carotid or central pulses. So for this stroke guy, because he's going to be a little hypertensive, we'll say that he's got good strong pulses here. It defaults to no JVD, brisk cap refill time, and there's no appreciable edema. Here you can write 2+ peripherals, pulses, 80 a minute, blood pressure we'll say 148/84. Skin, pink, warm, dry, appears well perfused. No chest pain. Done. Okay, so that's our respiratory and cardiovascular. We'll come to our secondary survey now. In this one, it breaks it down by system, similar to the neuro, airway, respiratory, cardiac. This looks for more of your deformities, contusions, abrasions, tenderness, punctures, all of your DCAP, BTLS stuff, and some more focused assessments on the abdomen, their skin, and if they've been incontinent or any issues through here. So you do not need to add anything into here. You don't have to click that. Findings, though, it's good standard practice to add in through here. So for his head, once you've done a couple of charts on the computers, it will start to recognize these fields and say, gee, most of the time, I write that their head findings are unremarkable. I write that his neck findings are unremarkable, or his trachea is midline and there's no GAVD. We can also say that right there pretty easily. We can say that his chest has equal rise and fall with native effort. There's no incontinence. So we'll say no obvious incontinence here. For comments down here, we can really talk anything we want about the abdomen. So we'll say abdomen non-distended, non-tender, no recent nausea, vomiting, diarrhea. Done. Back, I don't generally look at people's backs unless it's a trauma or there's something going on back there, so not examined. Extremities, we'll say unremarkable again. And skin, we talked about already, pink, warm, dry. All set. Moving on to the next page. Okay, so this brings us to our activity log. This is where we are going to import our vital signs. This is where we're going to add our actions. So any of the interventions we did. In our previous old charting system, this required you to toggle back and forth between two different screens. In your vital signs, you had to put in tons of data points. That no longer exists in EMS charts. That doesn't happen in this. You don't have to toggle back and forth. Everything is in line, and it looks more cohesive and kind of flows a little bit better as compared to what we had before with the Zoll's RescueNet software. So to import our cardiac monitor, we're going to come down here to where it says EKG import. If you utilized HandTevi and you imported it and you uploaded it, you can import that case from right here. But we're going to import from our monitors. And we're going to tell it. So these are the current cases that are up right now, but I want to go to an older one. And I'm going to say it was 7 days ago. Sorry, we're within the last 7 days. So we're going to come back to April 27th. And we want to do this 2240 one right here. So this will align with the times that we have in the chart already. So I'm going to select this right here. And this part's pretty important and pretty user-friendly. So we're going to wait for that to load. And then this white bar right here, we're going to drag down. Oops. We're not going to highlight that whole thing. That's silly. Let's bring that down. There we go. Okay. So here you see we put this gentleman on the cardiac monitor at 2241. We know that we got on scene and next to the patient at 2240 because generally this box will open up and will leave enough room right here for you to see what time you got to the house or to the location, what time you got to the patient, what time you left, and what time you got to the receiving. That way, when you're selecting your vital signs and your interventions, you can make sure that they're all timed out correctly and you're not selecting anything. Say you take him to CAT scan and the nurse asks you to leave the patient on the monitor. Technically, you've already transitioned patient care. You don't need to document vital signs that were obtained in CAT scan. That can all be documented on the hospital side. So if I had vital signs that extended well beyond 2254 here, I don't need to import those. Those can all be documented by the hospital. So we're going to pull this one in. Anything that is checked is going to be pulled in. So we can pull this in. We did a 12 lead at the same time that we got in the house with this guy, generally on strokes. So this call right here was not a specific stroke patient. This was probably a chest pain patient, but for the simulation and for demonstration purposes, we're pulling this in. So, but it's a good one to pull in because we see a 12 lead is done right here. So this is 12 lead start. This is 12 lead end. You do not need to pull both these in You just need one of them. This is not the actual snapshot of the 12 lead. This is going to show you what time you obtain the 12 lead. So we'll leave the 12 lead start there. We're going to pull in this vital sign right here. We're going to scroll down. We'll pull in this one. And we started transporting right around that time. So I'm going to say I tossed my IV in at this time right here. And then I'm going to say, because he's a stroke patient, I called the hospital right here at about this time. And then I got another blood pressure right here at 2254 when we arrived at the hospital. And that's it. Anything below this, I'm going to uncheck because we don't need to pull it in. So the other important thing down here, so this is considered events up here, and this is considered reports. The reports, you do not want to pull in all of this data. So this is anytime either an alarm event happened on the monitor or there was some type of change. These you do not want to pull in. The only thing you want to pull in are your EKG strips. And you can pull in as many of these as you took or as many of them as you want. Say your first 12 lead strip, there was a lot of artifact and you don't want to include that in the report. You can uncheck it and not pull it in. And say your second one is a better one. You could select your second 12 lead. It will say 12 lead EKG strip 2. You can select that and pull that one in. If all of your 12 leads were appropriate and adequate and they show an evolving STEMI, you can pull them all in. So we're going to pull in just this. If we were to pull in and leave all of these intact, this is going to create a report that is greater than 20 to 30 pages long and is going to infuriate the hospital. This will generate a call from the one of the registrars at the hospital saying, you need to tell your crews to stop importing so much data. It's bogging down our system. So we're going to deselect all of that and only import the 12 lead EKG. So right now we're going to hit import. It will pull in our vital signs and evidence that we did a 12 lead right here. If I want to review my 12 lead, I can come over to the side here where it says attachments. I'll hit this. I can see 12 lead EKG strip number 1 right here. It'll pop up over here. And here's my 12 lead. If I couldn't remember what it looked like, that's what my 12 lead looked like. So I can come back and review that. The important thing to know here in EMS charts is it does not pull in your interpretation or what the monitor interpreted it as. So we'll go over how to put that in next. So we'll say right here, we're going to start here with our first set of vital signs because this is our at patient time. So 2241, I was at the patient at the same time. So heart rate was regular. This was done by the monitor. This is all good. Respiratory rate we can change here because we know these aren't very accurate. So we're going to say he was breathing at 14 and it was normal. We had the engine crew, engine 4 as we were walking in, was getting a blood glucose level. So we know that was 130. We'll add that right there. He was alert. His GCS was hit the number 4, tab 5, tab 6. And he had no headache. So we're going to say 0 over pain. That's it. That's all we have to add up there. All these extra fields do not need to be done. For a stroke scale, because this is a stroke patient, we're going to say, yep, we know that that was positive. And we'll come back through here and we'll say, yep, there was forced deviation. There was some weakness and he's got that. So it's still a 6. All set. Because at this point in the house, we had the patient on the cardiac monitor. We're going to say cardiac as an action. And then down here, we're going to say the patient is met and report received from the engine 4 crew, the patient and his family. Last known well 30 minutes ago. He is found with the stroke symptoms noted above. Patient is secured to the stair chair for safe from his home. Done. And we can go a little further. to the stretcher and ambulance for further evaluation. Okay, I spelled further wrong. We'll right click that. There it is. Done. As soon as I hit save, it's going to open a new window because I added an action. So we put this guy on the cardiac monitor. So we're going to select who did it. So we'll say Danny was right by my side while I was getting a little bit more of the story. So Danny tossed him on the monitor for me. It will default to your role. So Dan's a medic, obviously, so it defaults to that. The baseline cardiac setting when you select it is cardiac monitor. Procedure complications, none. Doesn't change them at all. And we'll say we can do that via protocol, save. That's our initial one there. Boom, done. Okay, so we got a 12 lead on this guy. So we're going to click this box. I don't have to put anything in here. Unlike the other Zoll EPCR program, the RescueNet program, where anytime there was a set of vital signs, you had to put in tons of data and information for every single one of them. Otherwise, it gave you faults. That doesn't occur in this program. So I don't need to add any of this in up here. This one, I'm simply going to add an action. I'm going to say cardiac again. I'm going to leave this 12 lead analysis right here because this says to the people reviewing the chart and to the folks at the hospital and to anybody else down the line that happens to review your report that a 12 lead was obtained at this time. So below here, I'm going to say 12 lead shows normal sinus rhythm with no acute ST or T wave changes, regular rate and rhythm. No acute findings, non-diagnostic. Done. Save. It's going to open up our cardiac box again. Again, we're going to say Dan was a pal and did it for us. We're going to change this to 12 lead EKG. We're going to set as none. We're going to say it's unchanged, and we can do that via protocol. All set. Okay, so now, because he's a stroke, we've been there for a couple minutes, we're going to leave. We've only been there for 6 minutes, so we're going to say right here, 22:45. This is pretty close to our leaving time. 22:45:59 actually is right at it. So we're going to come back through here. Again, we'll do a couple of these. His respiratory rate was still 14. It's still normal. He's alert. It's 4, 5, and 6 still. And he's got no pain. So down here, we're going to say that we initiated transport. Bull General Main Campus. Hemodynamic stable. Patient remains awake. And we'll save that right there. Okay, so now we've started our transport. We added these 2 extra ones in right here because we're going to say that this is where we toss the line in. This is where we... Actually, let's toss the line in here. So we had already come in here. If you think that you can't go back and add things, you absolutely can. So let's go back in here. We'll add in an action. And we'll say right here, as soon as we started driving, we toss that line in. So I'm going to hit add. And now I'm teching. I put it in his left AC. I did an 18. It didn't change him. And we can do that via protocol. I do not need to talk about here that I appropriately cleaned the patient's arm, that I put the IV in, that I confirmed that it was patent with a brisk flush and return of blood on draw. I don't need to put any of that in here. It is assumed and known that your peripheral line that you inserted, because you're a paramedic, was an 18 gauge and left AC. It took you 1 attempt and it was successful, and there were no complications. That's it. You don't have to double document anymore like we used to, where you'd have to do the IV intervention, and then somewhere in your narrative you would write, I started an IV at this time and it flowed fine and it did whatever. So up here, because we're good helpers of the hospital, we're going to say labs drawn for LGH. Perfect. Okay. And then we had talked about just after transport, we were going to notify the hospital that we're bringing them a stroke patient. So we're going to click on this one right here. We're going to get rid of this erroneous 41. We're going to say that's 14. And we're down here going to say hospital notify. So we're going to hit add. And because I'm in the back, I'm going to say I did it. I did it over the cellular line. What type of a report was it? It was a stroke alert. Potential registry candidate, you can add this if you want. It's not required, though. You can leave that off. This one will open up to what type of patient was it. So if it's more than one, if it, say it was a trauma patient and a spinal cord injury, you could select both of these. But generally, you don't have to select anything in here because for the most part, it'll be selected already based off of what you select here. So I notified Lowell, requested the stroke alert. That saves as an intervention right here, just like we used to do. It used to be called destination team pre-arrival or pre-arrival destination, something like that. So that's all there. That's good. In here, if we want to make a note and say Lowell General notified of fast ED score of 6, we can put that in there, and that's good for that. So down here, we'll say this one we pulled in because we're going to use it as a different intervention, but now we decide we don't want it anymore. We can hit delete here, and this will pull this one right out of line. And in here, we can say the patient remains awake and alert, continues with left-sided weakness and right forced gaze, no neuro changes en route, hemodynamics remain stable. Okay, so we're going to right-click these. We'll change these. It tells us that we're horrible at spelling. On arrival at Lowell, a brief report was provided to ED provider Dr. Corvey. Patient direct to CT. A full report was provided to the patient's RN in CT. The patient remained on the Medic 3 monitor for the duration of the scan. So I will generally add whether I left the patient on the monitor for a CAT scan at Lowell General or whether I took the patient off. If you're going to take the patient off the monitor, make sure that the nurse is notified and that the nurse is okay with it without somebody, whether it be a tech or herself or himself, grabbing a travel monitor. If a patient comes off a monitor and an event occurs in CAT scan or really anywhere else in the hospital for that fact, and they're unmonitored, it triggers a safety report. And that safety report is really extensively reviewed. And you don't want to be involved in that as saying, nope, the medics just ripped it off and threw the monitor out of the room. It's a cooperative kind of thing that we do together. It's very easy for one of the staff members to get a travel monitor. Just make sure they have one that they can come over with. All right, so we'll save this one here. And that's our activity log. So it's a pretty straightforward stroke patient through here. We documented a lot in the HPI about our initial exam. We documented a lot in the neuro, airway, respiratory, cardiac. We ripped through this pretty quick. I talked a whole lot through all this. We've got about 25 seconds left on this recording. And you can see up here that I have no current errors. If I needed to get a signature, we're going to go to miscellaneous forms right here. The patient can sign on the screen or a staff member can sign on the screen. It's going to be standard signature right here. So we're going to